Hi, I'm Di North. I'm a general practitioner and I work for the Goodfellow Unit at the University of Auckland. Today we're doing a talk about the brain and pain. We're lucky enough to have with us today Gwyn Lewis, who is the Associate Professor at the Auckland University of Technology and a neuroscientist. Hi Gwyn.
Hi.
Could you tell us what is pain?
Sure. So pain's defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So there's just a couple of things I wanted to highlight about that definition, and that pain is both a sensory and an emotional experience. So the sensory component is, if you whack your arm, you can say, oh, ouch, that hurt, it's in my arm. It's about 7 out of 10 pain. But there's also an emotional component to it, and that it makes us upset, afraid, scared. So it's not that people experience pain and then become upset about that, is that emotional component is part of the pain experience itself. And the last part of the definition of pain is that it can be described in terms of such damage, which means that if someone says they're in pain, they're in pain. It's a purely subjective experience, and that we can't say to someone, no, you don't have pain, if we can't see any indication of tissue damage. So if someone describes something that they do have pain, then we have to accept that they have pain.
Can you give us an overview of the pain pathways?
Sure. We'll start out in the periphery with the nociceptors. So these are our receptors that detect tissue damage, whether that's mechanical, thermal or chemical. And they're present in most tissues of our body. There's a couple of different types. So they're known as A delta and C fibres, or sometimes they're referred to as type 3 and 4 fibres, depending on where they are located. So the A delta fibres they're a bit bigger and they're myelinated, so they conduct faster. So they give rise to the fast pain, that immediate sharp sensation when you first injure yourself. The other ones, the C fibres, are smaller in diameter and they're not myelinated, so they conduct a lot slower. So they mediate the second pain, that dull aching sensation that comes afterwards. And because of what they synapse with, they also tend to give rise to the emotional experience of pain. So the information from the nociceptors then goes into the spinal cord, into the dorsal horn of the spinal cord. Again, they synapse onto a couple of different types of neurons there. One of them, right in the superficial area of the dorsal horn, they're nociceptor-specific receptors, and they only get their input for nociceptors, and that's quite an important point for when some things can go wrong. The other type that they synapse onto are wide dynamic range neurons. They're located a little bit deeper in the dorsal horn, and they get their input from nociceptors and non-noxious receptors such as mechanoreceptors. And again, that becomes a little bit important later on if things go wrong with the nociceptive system. From there, the signal goes up the ascending pathways to the brain. There's quite a few ascending pathways. A couple of them stop off in the brainstem, and they're responsible for some of the reflexes associated with pain, so drawing our attention to it, so we automatically will look at something that hurts. One of them also goes to the reticular formation, so it makes us aroused, and that also captures our attention, which is really useful. And then some others go up to the brain. The one that goes to the primary somatosensory cortex, that gives rise to the sensory component of pain. So it conveys information about the location and the intensity of pain. But there's another pathway that goes to the limbic system, and that's the one that's responsible for conveying the emotional experience of pain. And that's the one that changes how we're feeling and making us upset or afraid of things.
That's fascinating. So what we actually are seeing is the nociceptor actually triggering not just the sensory cortex where we can isolate where the pain's coming from, but also it can arouse us, stop us from sleeping, and it can also trigger that whole emotional cascade of responses to pain.
Yeah, that's right. And I think you can see from that they're actually quite separate components of the nociceptor system, the sensory part and that emotional part, but they're very heavily intertwined in that you get the sensory and emotional experience together as part of a pain experience.
And the body has mechanisms to turn up and turn down pain.
Yeah, absolutely, and it's quite normal that we modulate pain in different situations. For example, if I was playing a game of soccer and I fell over and grazed my knee, I might not even notice it and realise that I had any tissue damage or injury until after the game, where I might look down and see it and it might start hurting then. Whereas if we sat here and I gave myself a paper cut on my finger while we were sitting here, it would hurt quite a lot. And so for the same extent of tissue damage, I would experience quite different levels of pain in those different situations. So normally what happens when we have an acute injury, normally we want to turn pain up straight away, because the whole point of pain is that it's a warning mechanism. It's telling us that we've got some tissue damage and we need to draw our attention to that, remove ourselves from the damage so that we don't cause any more problems, and get away from it if we need to. So our immediate response to tissue damage is that we want to facilitate that signal as much as we can. And then as the tissue recovers over time, we then want to turn the pain down, because that will encourage us to get moving again, start being active, and start using that damaged part of the tissue again. So we have mechanisms to both turn the pain up and also to turn pain down.
So let's look at each level of the pain system, of how we do turn up and down pain.
Sure, so we can again start out in the periphery, and one of the first mechanisms that we have when we have tissue damage is that we get inflammation. And those inflammatory chemicals, they sensitise the nociceptors, so it makes them easier to fire. So that for a given level of input, you're going to get a larger response coming into the central nervous system, into the spinal cord. So that's peripheral sensitization, and it gives rise to what we call primary hyperalgesia, or an excessive pain response at that level of tissue damage. Glial cells can also contribute to that. It was long thought that glial cells did nothing at all, they were just structural, but we know that they release pro-inflammatory cytokines which help with the sensitization of the nociceptors.
Where are those glial cells?
So they're located around in the periphery as well as in the spinal cord as well. In there. So that also explains why our non-steroidal anti-inflammatory drugs can reduce pain, is that they reduce the inflammation, they reduce the production of prostaglandins, which contribute to the sensitization. So our non-steroidals will reduce the sensitization and then turn down the sensitivity of our nociceptors. Cryotherapy or icing is also another mechanism out in the periphery that can turn down pain. It reduces the amount of blood flow, which stops the bringing in of those inflammatory chemicals. So again, it reduces the sensitization, but it also slows the conduction velocity of the nociceptors and other neurons, and so that it can stop the barrage of input going into the spinal cord. So then we can move into the dorsal horn in the spinal cord. So as soon as you get some pain and tissue damage and we get a signal coming in, we get lots of changes that occur within the synapse between the nociceptor and the dorsal horn neuron. So firstly, more receptors become available, so there's a larger number of them, but also different types of receptors become available as well. The nociceptors also, they release more neurotransmitter, and all of that helps to facilitate that signal. So essentially it turns the signal up, so for any input that comes in, we get a much larger input going up to the brain, so you get a larger pain experience. There are also other connections within the spinal cord that are normally inhibited, and we lose that inhibition. So there's more connections, so those nociceptors may go to slightly different areas within the spinal cord as well. So you can get an excessive pain response surrounding the area of tissue damage as well, or secondary hyperalgesia. Our glial cells will also contribute within the spinal cord. They facilitate the release of neurotransmitter from the nociceptors. So again, they're bumping up that signal, and they can also help to sensitise the dorsal horn neurons as well. So all those factors are called central sensitisation. Okay, well, we're making it easier for those dorsal horn neurons to fire. And initially that central sensitisation is really good and useful, in that it's helping to facilitate that pain signal so that we experience more pain and we become more aware of it.
We also have mechanisms in the central nervous system that turn down the intensity of pain.
Yeah, we do. One of the really common ones that most people have heard of is the gate control theory of pain. In the gate control theory, we provide a touch stimulus or a rubbing stimulus around the area of tissue damage, and that activates a mechanoreceptor. And within the spinal cord, they synapse onto inhibitory interneurons, which prevent the release of the neurotransmitter from the nociceptors. So they're turning down that communication, the signal from the nociceptor onto the dorsal horn neuron. So that rubbing around the area of tissue damage will reduce the pain from that area for as long as you continue rubbing. TENS machines, so transcutaneous electrical nerve stimulation, activate the same mechanism, but instead of activating the peripheral receptors, they activate the axons directly. And those mechanoreceptors, the axons are larger diameter, so when you apply electrical stimulation over them, they fire first, and so you then start to send that signal into the spinal cord. It activates the inhibitory interneurons, and it can reduce that pain signal in exactly the same way as rubbing around the injured area.
So as we move up the spinal cord to the brainstem and the brain, that too can intensify and reduce pain.
Yeah, absolutely. The brainstem, in fact, is one of the key areas of pain modulation that we have. There's a number of centres within the brainstem which send pathways back down to the spinal cord that can both turn pain up and turn pain down. And as we said earlier, the brainstem is one of the areas where those ascending signals stop off. So as soon as we get a pain signal, we can immediately modulate it by activating these pathways within the brainstem. So normally, as I said, we want to try and turn pain up, and we can turn on our facilitatory pathways that we have. We also have our key inhibitory pathways that come down from the brainstem, and the two main ones there use the neurotransmitters. One of them uses serotonin and one uses noradrenaline. So our medications that are noradrenergic or serotonergic reuptake inhibitors, what they are doing is they're facilitating the amount of those inhibitory neurotransmitters that we have within the spinal cord and trying to enhance the effects of those descending inhibitory pathways. And of course the other mechanism we have are our natural or our endogenous opioids. So they are released within the brain, the brainstem, the spinal cord, and even out in the periphery. And we have receptors for them within all of those locations. So they're normally released when we have a stress response. And so what it means is that straight away we have this opioid system where we can turn down pain in multiple places. And they act in different ways based on where they bind in the different locations. But in the brainstem, when opioids bind within the brainstem, they turn on the inhibitory pathways and they turn off the facilitatory pathways. So both of those will result in an inhibition of that ascending pain signal.
So for our survival, we have some pretty impressive techniques to control pain within the body itself, to reduce pain so that we can carry on, get out of a dangerous situation and get to a safe place.
In some situations, it wouldn't be beneficial for us to facilitate pain straight away, and then it would be more important that we need to remove ourselves from a situation of danger. So in those situations, we can immediately release opioids, turn on our inhibitory system until we're able to escape and get away from the danger. And then once we've calmed down a bit, that's when we would then start to experience pain. A really good example of that is in a severe trauma case where they may not be experiencing pain initially, but then once they get to hospital, they then may get an excessive pain response because the adrenaline has had time to wear off.
And as we go up to the brain, it too can modulate pain through a number of pathways.
Yeah, and I think this is one of the strongest areas that we have for pain modulation, and that what people are thinking, what they believe, how they're feeling, all of those can markedly influence the amount of pain that they experience. Those limbic areas of the brain that we mentioned earlier where the ascending signals go to, they communicate with our brainstem pathways. And so pain influences our emotions, but our emotions will also influence pain. So if someone is upset, they're sad or they're depressed, it increases the amount of pain that they experience. If you're attending to a painful stimulus, if you're watching while someone is giving you an injection and you're giving that stimulus attention, it increases the amount of pain that people experience. if you're expecting a large amount of pain, if someone tells you that this is going to hurt a lot, it's going to hurt more because that's your expectation. So how people think about the amount of pain that they're going to get will strongly influence how much pain they actually experience. And that also works with pain treatments. How effective someone thinks a pain treatment is going to be will very strongly influence how effective it is. And that if they believe that something might reduce their pain, it is far more likely that it will have an analgesic response. And as a clinician, the way that you present treatments can quite markedly influence how efficacious they are. And that you could take a treatment that is really physiologically ineffective, but make it effective simply in the way that you present it by convincing a person that you think it's going to be effective for them and reduce their pain. In the same way, you could take a treatment which is physiologically active and should be able to reduce their pain. If you present it in a way where the patient thinks, I don't know, I don't actually think it's going to work, then it's less likely that it's going to be effective for them. So you have to take into consideration what people's thoughts and beliefs are about their pain, the sort of mood that they're in at the time, because all of those things will influence the amount of pain that they experience and how they respond to treatments that they are receiving.
So how does that placebo response actually work?
Yeah, it's a really interesting response in that when someone expects they're going to have pain relief, the body acts and produces our own endogenous opioids. So the body reacts as though it's actually getting pain relief. It thinks it's going to get pain relief, so it activates its own pain relieving mechanisms. And so when someone takes something, which could be a placebo pill, but they think it's going to be effective for them, they will produce their own natural endogenous opioids and their pain is reduced. So it's a real physiological response that is occurring.
So we're going to move on to acute becoming chronic pain. It's a real problem for us in general practice.
It is. Chronic pain is a big problem. At the moment, about 19% of New Zealand adults have chronic pain. So that means that they experience pain on most days for at least 3 months or more. That's normally the definition of chronic pain. So that means about 1 in 5 adults have chronic pain, and that's hugely detrimental for them and has a large impact on their life, the lives of their families and also society.
So why does acute pain become chronic?
Yep, that's a very good question. It's really great for us that we have this very flexible pain system and that we can turn pain up and down at multiple locations within our nervous system. But it also means that it can go wrong in multiple places. So there are lots of ways that things can change within the pain system that mean we have this sustained ongoing pain, even though any injury that we may have sustained has recovered and that we no longer have any tissue damage. So our body, our nervous system adapts to the functional demands that are placed upon it and where it thinks signals are important. And that it's initially facilitated this pain signal and turns it up, and then it normally turns it down. But sometimes something goes wrong with that process and we continue to facilitate those signals and we don't turn on those inhibitory systems.
So let's think about that from the periphery to the central system again. How does that occur? Where do we go wrong in the periphery? Yeah,
so one part that is important is if we have damage to the actual nociceptors themselves, let's say out in the periphery, we've got some nerve damage, then they can fire spontaneously. The axons can fire spontaneously and send signals in. It can also occur if you might have neuropathies where you might have, say, some damage around the myelin, protective sheath around the axons, and it can mean that they just start firing when there hasn't been any input at all out in the peripheral tissue. In those cases where there's damage to the actual nociceptor or the pain system, that is what we call neuropathic pain. So when there's damage or a lesion to the pain system, that is neuropathic pain. And it's important to be able to recognise when someone has neuropathic pain contributing to their pain experience, because the way that we manage that is quite different from when they do not have neuropathic pain. Essentially, we need to treat the nociceptive system when there is neuropathic pain, but we need to look at other areas when the pain is not neuropathic. There are also sustained changes that can occur within the dorsal horn. So I said initially, central sensitization is very useful for facilitating our pain signal so that we're aware we have tissue damage. But if that is sustained and it's not turned down, we then get our sustained central sensitization. And in those cases, what can happen is we get more structural changes within the dorsal horn. We get new connections forming. Sometimes our mechanoreceptors, our touch receptors, will start invading in and synapse onto those nociceptor-specific neurons, the ones within the dorsal horn that should only get their input for nociceptors. But if they start getting signals from our touch receptors, when someone touches us, we then feel pain. We can also get a loss of our inhibitory interneurons, so we no longer have that ability to turn down pain. So there's lots of different structural changes that can occur within the central nervous system, within that spinal cord, which they take longer to occur. So it normally occurs when you have an ongoing signal coming in from the periphery. So it's why it's really important to manage acute pain. Because if you get a sustained input, you're far more likely to get these more structural changes that occur within the central nervous system. And those are the ones that are more likely to stay, and so that you continue to facilitate pain. And people get stuck with that amplification, so that any input that they may get out in the periphery, whether it's just a light touch or a brush, gets interpreted as pain.
So in general practice, we're seeing more of the complex regional pain syndrome.
Complex regional pain syndrome is a defined condition with various diagnostic criteria, of which normally they will have some degree of central sensitization. But you can also get central sensitization in other chronic pain conditions. So for example, in osteoarthritis, they may have central sensitization. So it's not specific to complex regional pain syndrome. One of the other things that can occur with central sensitization is that within the spinal cord, our dorsal horn neurons, they communicate with each other up and down a few segments. So it can also spread, and that can lead to why people get chronic widespread pain, and that it's not just localized to one area. So a good example of that is people with fibromyalgia, and where it's located in multiple regions. And in those cases, they're likely to have sensitized central nervous system in multiple levels of the spinal cord.
So when someone gets a central sensitization, is it reversible in any way?
Yeah, our nociceptor system, our nervous system, is very plastic. It can change, so it can adapt in good ways and in bad ways. So when it's a more sustained central sensitization, when you've got structural changes, yes, it can change. You can reduce that. It does take a little bit longer though. Whereas the initial changes are all neurochemical. It's about releasing neurotransmitters and different receptors, and they can change back again very, very quickly. So it's not as though they're now stuck with this amplification, but we need to try and kind of figure out sometimes about why is it amplified, and why has that occurred, and what do we need to do to try and help turn that system back down again.
So who's more likely to get this chronic pain?
Yeah, so there's a few things that we know that make people more susceptible to having chronic pain. One we know is if they've had an initial injury, it's the intensity of pain at that initial injury and how well that pain is managed early on, and that if they have a long periods of high levels of pain, they may be more likely to experience chronic pain. But then a lot of other factors are psychological factors. So people who are very anxious or happen to be depressed at the time, people who focus on their pain a lot, who are what we would call catastrophizers, and who become very, very worried about the pain and what it means for them, they are more likely to experience chronic pain. And it's very interesting in that often the physical findings and what we see, for example, in low back pain, there's very little relationship between what we might see on an MRI and how much pain someone experiences and how long they experience that for. For example, we know that some of the biggest predictors for return to work with chronic low back pain are how well they get along with their work colleagues, how many times they've been married, what they think is to blame for their back pain or why they think they have back pain, and what their expectations for return are. So those factors are far more psychological, psychosocial factors. So it's can be more important to deal with those sorts of issues where we're looking at the person's, their stress, their relationships, financial pressures, what's going on in their work environment. We're far more likely to have a successful outcome if you look at those factors rather than looking in their back.
So the management of pain in primary care is extremely complex. Can we now shift to look at the management of cancer and the pain ladder that we have discussed for many years?
The WHO pain ladder, it's been around for a number of years. I think what some people didn't realise is that it is specific for cancer pain. So it's not appropriate for acute pain, neuropathic pain or non-cancer pain. It has been criticised in recent years about how useful it is and whether we necessarily need to follow all those steps within the ladder. And what the new view is one, questioning the need for using weak opioids, and one also questioning the need to actually step up the ladder. And that what we think now is that it's better to manage the pain in relation to the severity of pain that they are experiencing. So if they've got severe pain, instead of stepping up the ladder, it may be more appropriate to take an elevator straight up to that second floor and get in there with the strong opioids right away. So now it would be better to look at what is their intensity of the pain and then matching up your analgesics with that. One of the problems with opioids, so one of the things to be aware of is that genetically we all have different types of receptors for opioids. So we have different types of opioids, they bind to different types of receptors. So it's important to know that not everyone will have a receptor for the opioid that you might be giving them. So if you're not getting an analgesic response with a particular type of opioid, then you want to switch it and try a different type that binds to a different receptor, because it could simply be that the person doesn't have a receptor and therefore that opioid is not going to be able to bind to anything and to have an effect. Another important fact is that with long-term use, tolerance is developed. So essentially our opioid receptors get tired and they don't work as well. So you have to increase the dose to get the same therapeutic effect. So then over time what's recommended is that you rotate the type of opioid that is being used and again switch to something that binds to a different type of receptor so those other receptors can have a chance to recover and get back a bit more energy again and so they can work properly.
So if we have non-cancer pain, what is the best management for this?
Yeah, so we know that managing chronic pain is very difficult. The gold standard treatment for chronic pain is multidisciplinary pain management programs where they have pain medicine specialists, physiotherapists, nurses, psychologists working together. But we know that access to those is very difficult. So in reality, what we need to do is to look at the person as a whole. We know that there's a lot of psychological influences on pain, so we want to have a look at their mood state. We want to look at their thoughts and their beliefs about their pain. Asking them about why do they think they're experiencing pain and what their expectations are. Providing people education about pain is highly important. It's one of the strongest tools that a clinician can have to be able to explain to someone how the pain system works normally and then how it may have changed within them. So now, for example, their pain system may be stuck on amplifying the signal and turning signals up. So now there's a disconnect between tissue damage and pain. It's that any input that's occurring out here is being amplified and experienced as pain. So looking at some of those areas, providing education, exercise and movement are almost always beneficial for people with chronic pain. Often having chronic pain means that you don't move much. Some people develop fear of movement and fear avoidance behaviours where they don't do certain activities. You can get deconditioning, which has its own secondary consequences for people with chronic pain. So encouraging people to be more active is normally beneficial. And I think making them aware that if they are active and they experience pain, it's okay. That doesn't mean that their back is falling apart or that their knee is about to fall apart. It's if you've explained to them that pain no longer means tissue damage, that it's okay to move and that you might feel pain and that's going to be perfectly fine. It's important that people don't go over the top. You don't want them to get stuck in this boom and bust cycle and that they overdo it. So a really good piece of advice is for people to do enough activity today so that they could do a little bit more tomorrow. And then also, of course, there's the pharmacological management.
So let's talk about the pharmaceuticals we can use for non-cancer pain.
For neuropathic pain, a good one to look at are our membrane stabilisers or gabapentin, because they can stop that spontaneous firing of the nociceptors when there may be some type of damage to the system. For when it's not neuropathic, probably the best lines of defence, you can try the gabapentin, but also amitriptyline might be a good option there. But I think it's important to know that morphine is not recommended for chronic non-cancer pain. There's no evidence that it is effective.
There's a lot of discussion about the overuse of opioids for chronic pain. Tell me why we shouldn't use them.
Well, I think the evidence is reasonably clear that there's no indication that it has an effect on pain, that it's a good way of managing chronic non-cancer pain. And we know that there are a lot of unpleasant side effects with taking opioids, and when there's no indication that they're going to be beneficial, it's not useful that people take these, and certainly not for long periods of time.
So pain is a complex system. What are the 3 things you'd like to leave with us today so that we can better manage pain in primary care?
Okay. So I think one of the important things is knowing the difference between acute and chronic pain and how we manage it, and that we manage them quite differently. In acute pain, if someone hurts, they need to stop doing that activity, and we need to manage their pain and reduce it. But in a chronic condition, that isn't necessarily true, in that if something hurts, it may be perfectly fine that they keep on doing it. So pain isn't a good guide for activity in chronic pain. Secondly, that chronic pain is very complex, and that we don't just need to look at the periphery. We don't just want to look in the back or in the knee. We need to look at the person as a whole and take a more holistic approach as to the way that we manage their pain, thinking about psychological factors, activity factors, as well as how we might add in pharmacological management. And the last point, I think, is that you want to remember that the nervous system is plastic. We can change it. People aren't stuck with a faulty nervous system forever. What we need to do is to work out how do we get it back to normal, and there are different ways that we can do that. We need to look at the individual and have a think about how can we change them. Can we address some of these psychological issues, and those may kick in some of our inhibitory pathways and turn down that amplification of pain in the spinal cord.
The brain and pain is extremely complex. Understanding the neurophysiology really helps us be able to talk with and explain what is happening to our patients. Thank you so much, Gwyn, for explaining to us the basics of pain again, and also for giving us hope that we can make a difference and we can turn off these centralised sensitisation pathways that are leading to chronic pain in 20% of our patients. Thank you so much.
Not a problem, it's a pleasure.